AMD.
Great, thank you. I want to thank John Nolan for inviting me to this meeting. This is an unusual venue for me. I usually talk about anti-VEGF medicines because I helped develop it, and I'll tell you the history of all that. I also want to compliment a previous speaker. He's talking about a very politically charged topic. In my field, it's very controversial, and that's why I was so happy that I wasn't charged with that talk, because you could only put your foot in your mouth. If you want to get grants, you can't talk against zinc. So enough said. I'm a little bit different. I am financially very, very involved in this situation. I'm a consultant for, a lot of companies. The ones that are really important for my talk, at least, is going to be Regeneron, Allergan. I'm helping develop their DARPin program. Novartis, I'm helping develop their SBIT program. Optotec, I'm helping develop their anti-PDGF drug. Bayer, I'm helping develop their regorafenib eye drop. I don't know if I'm supposed to say that, but yeah, I guess so. Genentech, I'm helping develop lampalizumab. Okay, so I also I invented a molecule called sRNA. The molecule I invented was called bevacizumab, and right now it's being licensed by a company that I can't consult for or do any clinical trials for in Massachusetts. I'm not going to mention them because that's licensed through the company that I founded called OPCO. So I'm also in faculty, though, at University of Central Florida, which allows me to have all these relationships, which is unusual for most academics. Now, I started studying macular degeneration when I was in grade school. The reason was my father was a professor at Harvard Medical School in retina. He was the partner of a guy named Charles Skeppens, who developed the indirect ophthalmoscope. So dinner conversations, when I had dinner with my dad, was talking about diabetic retinopathy and macular degeneration, because that's the only thing we had in common. So when I think of macular degeneration, I think of it from the eyes of a child, a 7-year-old. And what my dad explained to me was that, you know what? I go, what is this macular degeneration stuff? Why do you have to go to surgery 36 times in a week to fix people's eyes? You know, this was a 7th grader. This was back in the 70s. He wrote the first book on vitrectomy. And he was doing lots of vitrectomies back in the 70s. And he said, well, you know what? Macular degeneration really is, you have a lot of bumps in the back of the eye. I go, okay, what are bumps? Well, there's 2 types of bumps. One is the dry bump, which is called drusen. I don't know what drusen was, but I'm not German. So, so he just said, well, there are bumps in the back of the eye. So I go, well, how do bumps in the back of the eye cause problems? And he said, well, you can also develop blisters in the eye, like this, like a blister. And this is how he explained it to me when I was a child. Blisters like a fluid blister or a blood blister. If you get a blood blister, it's really, really bad. And then, after dinner, he would say, when you grow up, you'll solve that problem. I know that. And I said, geez, that's a big deal for a 7-year-old. I'm going to solve the problem of blindness. And unfortunately, that stuck with me. It's like you have the angel and the devil on the shoulders. So I have my dad going, you got to cure blindness. You got to cure blindness. He's always on the back. And so that's why I started on this whole journey that I call it. Now, in the dinner conversation, we had this conversation about something called factor X. Now, there's a lot of factor X's. Factor X in cancer, factor X in arthritis, the factor X in macular degeneration and diabetic retinopathy. This factor X was a factor which caused blood vessels to grow in the back of the eye, and it had all these criteria. It was soluble, it was a potent vascular permeability factor, a potent vascular mitogen. It was also sufficient to produce findings of diabetic retinopathy and exudative AMD, and if you inhibited it, you would reduce all that, and you would cure blindness. This is the conversation I had in dinner. Usually it was Sunday dinner, because that's the only time I ate dinner with my dad. What we eventually found out, and this is a story that I started back in 1989, right? Actually, back in 1993, I met Paul Bernstein, who's right there. He was the retina fellow, and I was a research fellow in a lab at Harvard called Judith Oakman's lab. And what we found was that this molecule called VEGF, which is it was discovered actually as it was a molecule in the liver fluid of acidic patients who had liver cancer. It was discovered by Harold Dvorak in his lab, where he actually isolated the protein from acidic fluid. This is back in 1982, I believe. Then what happened was he called it vascular permeability factor. Then in 1989, Napoleon Ferrara, and there were several groups that found it. I'm not going to name all the groups. It's been a long time. They found out that it was also a very potent vascular mitogen. And Napoleon Ferrara in Genentech, who was working at UCSF, he was a postdoc in a lab in UCSF, decided that this was the same molecule that Herod Dvorak found in the liver acides. As a result, what happened was we then saw a molecule that had several of the characteristics of factor X. It was a vascular permeability factor. It was also a vascular mitogen. Then the next thing we had to find out was it soluble? We also were working with a guy named Napoleon Ferrara, who was at Genentech, who was able to clone it and produce the molecule. That was a coup, right? We had all the things to do the right experiments to show that VEGF was factor X. Now, VEGF works with two receptors, VEGF receptor 2. It binds, and it goes through tyrosine kinase pathways to cause angiogenesis and vascular leakage. Also downstream of this activation is NF-kappa B. And NF-kappa B binds zinc. And so that's why that was the science behind the concept of using zinc at that time. And that was a sort of an inside concept that we were bantering about when AREDS was being developed with Joanna Seddon and that group. So that was a concept that I guess, I don't know, we knew that it could be a good anti-angiogenic. And that's why it was used, right? Now, is it? No. But you know, that's another talk. Now, what I set out to do back in 1993, when I got to Harvard and I was working in Judah Folkman's lab, was we set out to prove that VEGF could produce all the findings of diabetic retinopathy or macular degeneration. So I got the purified molecule, VEGF, from California, and I injected it into normal eyes of non-human primates. And I produced pretty much all the findings. And this is sort of my sort of work for my first 4 years or so, you know, working on this back in the 90s. Actually, in ARVO, in 1995, there were 5 papers on VEGF. 5 papers. I was on 3 of them, and the 2 others were also from my lab. So we really introduced the concept of VEGF back in the 90s. Now, what's interesting is that when you inject VEGF in a dose-dependent manner, you can produce the findings of microaneurysms, you can produce neovascular glaucoma, iris neovascularization, macular edema, neovascularization of the disc, and also pre-retinal neovascularization, which defines all of the findings of diabetic retinopathy. We also then subsequently injected under the retina and found that it could produce choroidal neovascularization as well. Okay? I have some slides of that, but it's too much. It's just all background. The big coup was when we worked with Napoleon Ferrara with a molecule called A461. A461 is now called Avastin. How many people here have heard of Avastin? Okay. So my job was to purify Avastin, which was designed for cancer, okay, so that I could inject it into the eye so I could do my experiment. You know how long it took me to purify that molecule? 6 months. 6 months of constant titrations, et cetera. It was very frustrating because when I injected it into a normal eye, it would cause endophthalmitis. Why? Because recombinant proteins carry a lot of endotoxin. So I worked with Napoleon Ferrara using columns to purify Avastin, or A461, so that it was purified to the point where I could inject it into the eye and do this experiment, which was one of the seminal experiments to show that inhibiting VEGF could actually stop this model of branch retinal vein occlusion. Well, fast forward to 2005, and bevacizumab is approved for the treatment of colon cancer. The one mistake that Napoleon did was he used the purified formulation and used all my assays to purify the cancer molecule to the extent that it could be injected into the eye. Well, a person that was sitting across from me in the lab, so I was in the Howe lab at Mass Eye Near, and then in Ted Dryge's lab was a guy named Phil Rosenfeld, who is now at the University of Miami. And he was very involved in the clinical trials for Lucentis and at that time Macugen. And he said, well, he had shown that I had purified this molecule so it could be used in an eye. And so he decided to inject a human just by drawing it out from the cancer drug, and he showed this. This is one of his first slides where he demonstrated a reduction after injecting Avastin of the, actually it's a vascular permeability. And now, as they say, that's history, right? But all along, we were developing Lucentis and Eylea and Macugen, and now we're developing more anti-VEGF drugs. Well, there's a problem. You know how you mentioned that people didn't predict geographic atrophy? I predicted that back in 2001. There was work done by Pat Demore in the Skepins lab, and she showed that VEGF is a survival factor for neurons, and actually had several models where she could cause sort of a glaucoma-type picture by injecting anti-VEGF therapies. So I knew it was limited, but the FDA in the United States only requires a 2-year study, so we couldn't see it, right? So you know, while this was all great and all, and I felt very proud that I helped develop this whole technology, I wasn't very happy because it was going to cause problems. I knew it in the future. Now, right now, the current standard is this. We inject Avastin, Eylea. Right now, it's really Avastin and Eylea at this stage because of cost. And we're injecting lots and lots of patients. I mean, our clinics are like this. So I'm a vitreoretinal surgeon. I inject 35 patients a day. I see 60 patients in a day, and that's 5 days a week, sometimes 6 days a week. Right? Just do the numbers. How much is that? Okay, just myself. I have 5 partners who do the same. Actually, they do more than I do because I do some research. Think about that. Think about the magnitude of that issue, that problem. And that is what convinced me to try to figure out how to reduce this burden. And that's what led me, actually, it was Paul and John who led me to this idea or this concept of using carotenoids as a way of reducing the burden of injections. Now, just like I did for VEGF, you've got to understand the pathogenesis. And what we found, you also have to figure out how to stop the VEGF stimulus. And I'll go over this in the slides of how the thought process of why it led me to this meeting, right? And why am I presenting actually in this meeting. So one of the papers that we did was by Masa Kurioki, who is one of our Japanese postdocs that was lent to our lab for 2 years. Masa was great. He was a great golfer, for sure. And what he did was he showed that reactive oxygen intermediates, or ROSs, or superoxides, could produce upregulation profoundly of VEGF. And that was a very, very critical finding. But look at the date. This was back in 1996, before anybody thought about VEGF as anything. So this paper is lost in the archives. It's actually in JCI, so no ophthalmologist has ever read it. It led us to the concept of what causes the VEGF upregulation in VEGF. In diabetes, it's ischemia. It's also something called AGEs. But in AMD, we don't have any of that. But we know it's a very oxidative process. As a result, we realized that free radicals, or superoxides, could increase VEGF. So what in the AMD disease would increase free radicals? Very simple. I mean, you have high energy visible light, A2E, also lipid peroxidation, protein peroxidation, and ischemia reperfusion. Those are probably some of the main factors that result in, I also left out one, it's probably the complement system. So a lot of the complement factors actually can upregulate VEGF, especially downstream complement factors. And so all the stuff you were talking about with CFH being aggregated is actually propagating this. I don't know how, it's a kind of a balance issue. I haven't really thought that through very well. Now, so AG, most people here know about the visual cycle. I mean, Paul Bernstein is actually, wasn't it, Paul, in your MIT thesis, you figured out all these molecules? Yeah, the guy's smart. Yeah. Well, think about it. On the tour, somebody told me that Cambridge was only second to MIT, and I think that's, Paul, that's where you did your research, right? In terms of ranking or something like that for prestige. Well, A2E is a bad molecule. We found out by Janet Sparrow's work that actually it was this lipofuscin that we find in autofluorescence. And we found that that actually is very indicative of the progression of AMD, wet AMD in particular, and also geographic atrophy. Now, A2E is a bad molecule, because if you shine blue light on it, blue light is the light that you see here in all these, the LEDs. So like this is blue light. Any of the LED lights or computer screens, et cetera, that has a lot of blue light. If you shine blue light on A2E, it actually causes an increase in free radical production. And that is, well, think of the optical system as a funneling of all the blue light. So why do you think we get macular degeneration? Because that gets the most exposure of blue light because it's focused by our lens, right into the macula. So it's a concentrated light that then gloms with A2E, causing a tremendous amount of free radical production. So this is the AMD pathogenesis that I've sort of been working with. You know, again, I started working on this when I was like sort of 7th grade, so I do a lot of block pictures. You know, I use very little graphs because I'm a simplistic guy. And so what we see here is that there are 3 pathways to increase in free radicals. Visual cycle, light, causing free radicals, increased VEGF. ARMS is a mutation that results in an impaired antioxidation. So low macular pigment, also work by many people in this room, have demonstrated that that causes increase in free radicals. Also, through the innate immune system, drusen conglomerate a lot of macrophages, which then also produce a lot of free radicals and also produce a lot of VEGF in general. So this is the whole pathway. Now, I am working on this pathway here right now with several innate immunity molecules that can inhibit the pathway, also macrophage manipulators. That's with biotech companies, because this is very hard to manipulate. This innate immune system is very hard to manipulate. But we have ways of stopping both of these. How is that? One is to stop using blue absorbing lenses, which is what I'm wearing right now, to block the blue light from getting my macula. I don't care if it comes from the side. But it comes to my macula, I don't want it, okay? The next thing is, well, low macular pigment is, from what I learned from the esteemed colleagues here in this room, is actually the best way to block blue light and also to add antioxidation. I knew zinc was not an antioxidant, but macular pigment is. And so what you got to do is you got to increase macular pigment. Now, this is I came about this when I heard a lecture from Paul in the AAO in Chicago back in 2010. He presented this paper, which demonstrated the singlet oxygen quenching of the different carotenoids. What really struck me, and I don't know if it struck anybody else in the room, because I remember, I don't know if you remember that, Paul, but I approached you after that, your talk, and I said, hey, Paul, you got to tell me about this, is that he demonstrated that the combination of mesozeaxanthin, zeaxanthin, and lutein would actually quench more than any of those individuals. He also showed that mesozeaxanthin was the critical, or the best, of the singular carotenoids to inhibit. That's what started me on this journey. That's why I'm here 4 years or 5 years afterwards, actually. And then John Nolan's work, I mean, you know, the work was coming fast and furious from this guy in Ireland. I didn't even know who John Nolan was, you know? You know, seriously, he didn't do anything with VEGF, so how do I know him? But he was doing all this work showing that meso, when you looked at macular pigment, like you compared it to lutein, lutein did not increase the macular pigment, okay, alone, but meso did. And then Dr. Landrum and Dr. Bone, I'm not sure, I think they were here. Again, I read their work, and they showed that the distribution of these carotenoids was so critical. In essence, what I found was the VEGF for prevention, or the anti-VEGF for prevention. Why? Because we already had an innate way of protecting our maculas, macular pigment. And we also found out that if we could upregulate that pigment, guess what? You have now developed a sink. Did you ever ask yourself this question? Why, if we have the genetic mutation in macular degeneration, do we develop it only when we get older? Right? Oxidation process requires time. It also requires a reduction in this. And that's what we have when we get older. Again, a lot of the people who work in this room, it's not my work, it's your work. But I'm just interpreting it. That's all. Now, hypothesis. Restoring macular pigment can reduce free radicals in macula and reduce stimulus for VEGF upregulation. So I had 3 questions. Can LMZ, or MZL, whatever you want to call it, supplements prevent need for injections in exudative AMD? Can it potentiate anti-VEGF injections in exudative AMD? And can these supplements also reduce DME? So I'm going to show you cases, and this is where I'm going to end. Caveat, this is not a study. I'm involved in 16 clinical trials right now. And if I was going to call this a study, I'd have to get IRB approval. I don't want to get IRB approval. It's too much of a hassle, and I have no grants for this. Okay? So this is not a study. So I'm presenting not a study. This is clinical observation. Caveat. MZL prevents need for injections in exudative AMD. My first patient, a UK gentleman. Okay? I see patients in the villages. It's the largest retirement community in the world. It has 115,000 over 55. Right? They drive around in golf carts. That's how they get around. It's around 1,000 acres, and they're all old. No, I'm not old, but I'm old, but they're all elderly. This guy was visiting his girlfriend, who was in the villages from the UK. And he developed metamorphopsia, and he's also had a prior history of family history of exudative AMD. He comes in, and you guys have a National Health Service here that doesn't pay for care in the United States. So he was my first patient, because ethically, I would have had to inject this guy. He had a small classic parafoveal lesion, and he had subretinal fluid, which would indicate that I would have to give him an injection of Avastin. But he didn't want to pay for it, because I guess in the UK, you don't pay for those kind of things, right? Right, so he said no. And said, well, so why don't you try this, it's called mesozeaxanthine, it's MacuShield. Oh, yeah, I know MacuShield. So he tried it. And what happened was that after 3 months of MacuHealth, which is what it's called in the United States, it didn't progress. It actually reduced. His vision kind of improved, and his symptoms went away. Now, I'm going to show you, this is 30 months now. I see him once every 4 months now, okay? And he hasn't needed an injection, and he's still seeing fine. Okay, next case. Okay, I'm yellow. This is sort of the summary. Another one, another patient, this is one of my typical patients, had subretinal fluid, had sort of some leakage, some ooze. Again, I was going to try to get her into clinical trial, but her vision was too good, 20/30. So I could do this, and I was waiting for her to get worse so that I could put her in a clinical trial. I don't know if that makes any sense, but that's how it works in the United States. After taking it, well, she couldn't get into my clinical trial because her vision improved, and she got rid of the subretinal fluid. Now, this is just recently. This was May 2015, so I'm here, so I'm not seeing her. Hello, bummer. But my guess is that my partners will have injected her already. Trust me, they will. Another case, 73-year-old drusenoid PED, okay? 6 months on MacuHealth, the drusenoid PED goes away. Now, this is not really classic wet. This is a drusenoid PED. We don't know what to call that. It's an RP detachment. But in 6 months with MacuHealth, it's gone. Second, can anti-VEGF injections in exudative AMD potentiate? Can it add benefit to my injections? And I'm going to show you my first case. This is a case of a baseline. I've been seeing this patient since 2012. And I wasn't giving them any supplements at that time. What I did was I was injecting them with initially Avastin. So I started on Avastin. And then I then started, Eylea came about, and then I started on Eylea probably in 2014 or around 2014 or so. I got compassionate use because I was one of the big recruiters for the Eylea clinical trials, so they allowed me to use it on certain patients. And it didn't really work. It didn't reduce anything. It didn't do anything. It just kept on getting worse. Unfortunately, insurance came about. I had to switch him back to Avastin. And this guy progressed rapidly. So you can see his vision 2050 to 2100. As soon as I switched him to Avastin, I couldn't switch him back to Eylea because his insurance wouldn't pay for it. So as a result, it kept on getting worse. So as a last-ditch effort, I started him on twice-a-day MacuHealth. Now, look at this date, 3/17/2015. John Nolan gave a talk in my meeting in Aspen, Colorado. And that's why I started him on 2 times a day, because of what we talked about in dinner. And look what happened. After this, 2160 to 2050, I gave him an Avastin injection, but and the PED, you can see it's still there, right? but it's much less, much smaller. The subretinal fluid is also much less. Okay, here, it's almost, the subretinal fluid, the PED is almost completely gone. Subretinal fluid is almost completely gone. And this after 3 months of 2 times a day, they're 20/40, and he notices the difference. That's pretty impressive. That's called potentiation of anti-VEGF therapies. Summary of case. Okay, I read. Okay. I'm going to show you, I have only 2 more cases, and I'll rush through them. Okay, here's a patient, again, who has a PED, metaphorphopsia, bang. 1 injection, and then on mesozeaxanthine, and bam, it's gone. If you inject a lot of people, you don't see that. Okay? I actually never see that. My friend in BU did a study on these kind of PEDs and using a Lucentis, and found that only 12% responded after 6 injections. 12% only responded. This responded after 1 injection, and it was maintained. Again, 6:30, I just saw this patient, right? And so you can see that on this, the vision is very good. Actually, this is reverse. It's 20/30 down here and then 20/40 up there. DME, this is the last slide, so I'm almost done. Again, I only started using this on DME patients. So I don't have many cases. I have now maybe 4 or 5 cases where this is a patient that, again, 20/30 doesn't make my clinical trials. I'm in 5 clinical trials for DME right now, okay? So I should be able to get him into the trial, but the vision is not bad enough. So I put him on this, and you can see there's already a reduction. I've been in over 20 phase 1 clinical trials. This is a signal in all of them, okay? I mean, and I've gotten 6 drugs through registration. So I know of what I speak. Conclusion, sorry. MZL demonstrates biological effects in terms of reducing subretinal fluid in both AMD and diabetic macular edema. Further studies are needed and can be performed without FDA guidance, which is great, because I work with the FDA, and I've been audited by them 3 times, so I hate that. It's awful. Similar to Avastin, MZA can be a lower cost means of reducing injection burden. Thank you very much. I don't have time for...
Thank you. It definitely asks for another trial, these observations, I guess, but there's some questions.
Yeah.
Hello. Do you know if HIF-1 alpha is involved in this upregulation of VEGF?
Not the free radical. No. Free radicals, they do, it's transcriptional and RNA stabilization. HIF-1 alpha is upstream of that. So it's not involved in this. In diabetic retinopathy, it is.
So HIF-1 alpha is not doing anything here?
It's not the classic pathway. So
okay, it's another.
For diabetic retinopathy, vein occlusions, HIF-1 alpha is classic. And
yeah, what, because
it's the hypoxia way, but free radicals work through a different mechanism of upregulating
free
VEGF.
radicals also induce HIF-1 alpha, so it's not here doing anything.
Yeah, but we haven't seen it. I mean, I've talked to a lot of people. I designed an siRNA for HIF-1 alpha, and I have the patent for it. So, of course, I've looked into it, and that's why I haven't looked at it in AMD. We're thinking of looking at it in diabetic retinopathy, though.
Okay, thank you.
Yeah.
In one of your examples, you pointed out that you use 2 macula health per day. What criteria do you base using 2 as opposed to the normal dose of 1?
John showed me data that said that 2 increased it faster. I think that was your most trial. You presented it in the meeting, and it was very quick. So, and then we talked about it. That's why. And you have to take it. You told me you have to take it separate, right? So, separated by time, so because you can't absorb it. Where's Steve? Oh, he's not here. Okay, sorry. Sorry, Steve. You were in and out of my meeting too, so
Stephen, I said I don't see from a dose response. I would think the 22 is probably the top end. But I said what Stephen Beattie does is for all these type patients, he does the very same as you now, and he asks me and we talk about. I don't see the rationale.
So we're simplistic clinicians. Yeah. We do dose response curves. That's what we do. I mean, that's exactly. So I guess I can understand why Stephen was the one that told us to do that.
the very back.
Yeah, Michael, thank you for your talk. Can you comment on the zinc controversy? I know being in North America, there's a big burden that we have right now as a clinician, whether to recommend zinc, what amount of zinc, to do genetic testing, to not. I mean, there's legal.
Well, I can't. I was the #2 recruiter for the AREDS 2 study, and I can't talk about that. Sorry.
Paul.
Okay. Yeah, I was a little surprised on some of your results in terms of the speed of, in the early speed of response.
I was too.
Earlier talks that we've had here, where it's looking very carefully at how the macular pigment responds. That you're seeing effects that are unexpectedly fast.
Very unexpected. Very unexpected.
Yeah, we need to really look at this a little.
Caveat. Remember, I told you this is not an IRB-approved study, and well. Nobody's going to fund this study.
Right.
I mean, I applied to the NIH, but it's not about AREDS, so I'm not going to get funding.
And I would say the other thing to be careful on, at least in my practice, where patients are nutritionally aware, I'm not sure how it is in Florida.
They're not nutritionally aware.
Okay, yeah, because in my practice, everyone has a sky-high macular pigment.
I know
By
that.
the time they come in with wet AMD, they're already.
See, Utah's a
already
great
saturated.
place, but Florida, we're the obesity capital of the United States. We have a lot of these all-you-can-eat buffet places. Yeah. No greens. No greens at all.
Okay.
Great.
Any other questions?
Thank you.
Yeah.
Final one.
Thank you very much. You had inflammation up there as one of the key pathways, and I wonder if you have any information on whether anti-inflammatories reduce the incidence or how
No,
important?
it's the innate immune system. So you have to manipulate macrophages. So the biggest strategy right now that we're using, and I'm working with several companies, biotech companies, where we manipulate the pathway of macrophages. And that's the way you can control the innate immune system the best. If you switch the pathway of the macrophages from M1, M2 to what we call the regulatory macrophage, you can use pentraxin 5. That will do it. It's a drug being used in myelofibrosis. And I'm working closely with that company. I don't know if I put it up there, though. So. Right. Thank you.
Okay. Let's thank the speakers again.